Welcome to Bart's Cardiovascular Simulation Lab. I'm Dr. Khalid Barakat, Director for Cardiovascular Simulation, and we're filming some simulation-based DOPS. The next one we're going to do is coronary angiography. As I've said previously, simulation-based DOPS do offer the advantage of interactive discussion with the trainee, and I think a much higher quality of feedback, but it's particularly pertinent currently with the COVID crisis. With a lot of these simulation-based DOPS, we can't do it on one station, and often we need 2, 3 or 4 stations to be able to address the different objectives of the curriculum individually. So with coronary angiography, we'll start first with a discussion about the case and then move to a simulated patient for consent. Kyriacos, I think you've just seen a patient on the ward, day case ward. Can you summarise the case for me then?
Yeah, sure. So it's a 60-year-old lady who's had recent onset of exertional chest pain over the last few months, relieved by rest. She's got no other relevant comorbidities at all. She's been started on some bisoprolol, statin, and aspirin, and she had a myocardial perfusion scan that has showed significant perfusion defects in the LAD, in the anterior territory. Okay. So she's still symptomatic despite this medical treatment, and she's come for a diagnostic angiogram before we proceed to PCI. Okay, so what are the indications for angiogram here? Summarise the 2 reasons. So she's got exertional chest pain, so stable angina, despite optimal medical therapy at this stage, and she's got a positive stress test, highly positive stress test, yeah. Okay, so you're going to go off to the ward and consent her for me? Brilliant, okay. Okay, Amanda, so to summarize, you've been getting this chest pain over the last few months on exertion, sort of central pain. Yeah. That's relieved when you rest. You've tried some medication, they haven't really helped much. Exactly. And you've had a test that has shown the possibility of compromised blood supply to the heart when you're exercising. So you've come for the procedure, which is an angiogram with the possibility of inserting stents. I'm just going to explain the procedure to you now, okay? And ask if you have any questions as well. So we're going to go in basically and have a look at the arteries of your heart. We gain access to your blood vessels through the artery in your wrist, okay? Where we put our wires and tubes travel all the way into the heart. Okay. We use the tubes to inject a dye, we call contrast dye, into the arteries. And by taking x-rays, we can have a look and see if there's any narrowings in the arteries that we may need to treat. If for whatever reason, sometimes it's difficult to get access to the wrist, we may have to do it through the groin, through a big artery in the groin. Okay. We will be awake throughout the procedure, so we'll be talking to you. You'll be lying on a table with a big team looking after you. Okay. We're going to give you local anesthetic in the hand or the groin when we go in to make sure we numb it up, and then put a tube in there to allow us to get into the arteries. Okay. Okay. That should be the most uncomfortable part. We'll also give you some medications to relax you. Okay. Good. When we have a look, it's possible there may not be any narrowings in the arteries, in which case we won't do anything more, we'll stop there. If there's significant narrowings, we'll go in and put stents at that time. Also, we'll let you know because you'll be awake. And if there's a possibility there might be problems there that we need to discuss in a meeting and with other colleagues, so we may tell you that, stop and discuss and then decide what we'll do afterwards. Okay. Any questions so far? No, that's okay so far. So I'll be awake. You'll be awake, yes. But with some sedation? Yes, okay. Indeed, yeah. Now, as with any invasive procedure that we do, there is a risk of complications with the procedure. The commonest, I think, are mild problems such as having some pain in your arm or the groin, some swelling or some mild bleeding around there. Additionally, you may experience some chest pain similar to the pain you get when you exercise when we're doing the procedure, when we're putting instruments in. The risk, it's very uncommon to rare to have any significant complications, but I need to list them to you so you're aware of them. The significant complications would include risk of damage to your kidneys because of the contrast we give, can be toxic to the kidneys. There's a risk of suffering a stroke during the procedure. Oh, really? Okay. There's a risk of precipitating a heart attack during the procedure if we disrupt something in the arteries.
Okay.
And there's also a small risk of allergy to the dye we give, okay, that we need to treat straight away. The risk to life is very, very small. It's very, very rare that someone dies of this procedure, but it is there. Overall, we would say the benefits of the procedure are greater than the risk. That's why we're proposing this treatment for you. And the procedure, especially in your case, would be more than 99% safe, so less than 1 in 100 risk of a significant complication.
Okay.
Do you have any questions about any of that?
How long does the procedure take?
So, depending exactly what we do, if we end up putting stents or not, from the time you come into the cath lab till you leave, it'll be 1 to 2 hours max.
Okay. And what happens if it doesn't work?
So if we're unable to get into the vessels, or if we can't treat what we find, we would stop. We wouldn't keep you there for longer than we have to. And we'd consider further options, either doing further tests down the line, or different tests, okay, or coming back with using different methods.
Okay. Thank you.
So Kyriacos, we're going to just have a look at you getting into a radial artery. I think the case we're going to actually do is femoral, but sure. I'd like you to show me how to get into the radial artery, what the equipment's about. So why don't you talk me through it?
So position the patient, identify the radial pulse. We already infiltrated the area with some local anesthetic. So I've given 1 ml of lidocaine, 1%. Made a bleb just over where I think I will go, and then infiltrate slightly deeper along where the sheath would go in.
Okay, and you do the sides as well?
Needle.
Okay.
Yeah, so bleb, and then I would go in to the sides.
Either side's perfect. Down. Okay. So when you give the local anaesthetic, how much do you give roughly in a radial on average?
So 1 to 2 mils usually for most patients.
And in your experience, what happens once you've given the anaesthetic? What does the pulse feel like?
So if I've given the right amount, the pulse should stay the same. Or if it weakens only slightly, it doesn't usually go away. So it doesn't make your life much harder.
But there's a bit of a balance, isn't there? Because if you give enough anaesthetic, it's numb, but if you don't give enough, then there's pain. Now, if the patient feels pain, what's been your experience?
So they could get spasm, which will make things much harder.
So you've seen people give 2-3 mils, presumably, with lignocaine at the top and in the sides. Why do people undergive? Because pain is an issue.
I think if people are scared they might lose the pulse and they won't be able to feel the pulse anymore.
So let's say you give a nice amount of local anaesthetic above and the sides, and given 3 mils, and there's a big large bulge there and a bleb, and the radial pulse has become a lot weaker. What strategies do you know of trying to get that pulse back?
Well, we can try and warming up the hand a bit if we can, or we could give them GTN, for example, to cause some vasodilations, a couple of puffs of GTN.
So you know, with lignocaine, it is acidic and it does cause vasospasm in itself, and that's why the artery can shut down. So one strategy you might want to try is to compress the bleb and occlude the artery with manual pressure for a minute. So that has a number of things. One thing, it'll dissipate the lignocaine, so the bleb goes. The second thing is it gives you the time for the lignocaine to work, because this is the other issue, isn't it? Not giving it enough time to work. And the third thing is, if you occlude the artery, you'll get a reactive hyperemia. So if you try this on your patients, you'll find that the pulse comes back bounding after the 2 minutes of pressure. So you might want to try that. Okay, so you've given your local anaesthetic, your pulse is now good there. What are you going to do next?
So I've got equipment here. I've got a needle, it's 2 mm needle, so I need this cheek rather, so I would need to use a transfixing technique where I go through the vessel, do a double puncture down of the back wall. I've got...
So explain that needle to me. Why is a transfixing technique? Why that here?
Because essentially that allows me to stabilize the vessel, and I've got the outer tube, which is what stays in.
Cannula, yeah.
The cannula rather. I withdraw the needle, the cannula stays in, and then I pull back on the cannula to regain entry into the vessel and then feed the wire in. So it allows effectively for That's again controlled by transfixing the vessel and then be more stable when you gain entry.
So
with the guide wire.
With that needle and hub system, can you just describe to me where the flashes of blood occur and when?
So the first flash of blood will come into the initial chamber here.
Into the needle chamber,
Into the needle chamber.
Okay, and then you know
and then
that...
it will come up. I'm numbing the vessel.
So if you show me, if you retract, that's it. Now if you show me the tip, if you look at the distance from the tip of the needle to the cannula, there's what, a couple of millimetres. So you know you've got a couple of millimetres to go before the catheter enters the vessel. Okay. So what's the other technique? The transfixation is definitely the best technique. Most of us have found that. What's the other technique for using that?
Well, if you use a needle, you can gain direct entry, if you like, and feed the wire. Just with the cannula.
And the needle. So the other way would be like a cell dinger, which is you go in with the needle, you get a flash into the hub of the needle, then you keep going, and then you see the blood track up the cannula, the white line on the cannula, up to the pink hub. Then you know that the tip of the hub is in the vessel. And then at that point, take the needle out. Now, people tried that previously, and the problem with that was they often lost position because it was a bit vulnerable. And the second thing was the likelihood of picking up endothelium and causing dissection was that much more likely, and hence the transfixion technique. So with that, you're going to go through the back wall, take the needle out, and then do you have the wire ready in the hub, ready to advance?
I would do that. So I will have one hand on the cannula. As I'm withdrawing, the wire goes in when I get my pool of arterial blood.
And then you have a very good amount of blood coming back, don't you? Yeah, okay.
And the last piece of kit is the dilator introducer in the sheath.
What size is
I've been flat. This is a 6 French one.
How do you know that?
Because I've seen it says 6 on the sheet there. It's also color coded.
Color coded. Perfect. Okay, go ahead. Show me how to get into this artery then.
So give me a look anesthetic. Feel for the pulse. Okay.
Okay. That's good. And then good, so you got that in.
The resistance.
Okay. So Kyriacos, now there's a femoral sheath in this lady, so we're going to do a coronary angiogram. I'll do the radiology controls for you. Just give me a shout about what you need. Is that all right? Go on then, let's talk me through it.
This is my 0.035 JT coronary to be able to connect.
So you're always keeping the wire in view. Sorry, that's the radiographer's fault. That's me.
Now we're at the aortic root. We're going to start with the right side.
No, left. What would you normally start with, left or right?
On the femoral axis, I'll start with the left side, with preferably a Judkins left fore catheter, first choice.
So why the difference between the radial and the femoral approach? Why left with one and right with the other? Or doesn't it make any difference?
So I think obviously the angles are different. We approach different vessels from the radial and the femoral side, but also I'm not quite sure the actual...
What's the highest risk lesion in the coronary tree?
Proximal LAD or left main stem.
Left main. So knowing the state of the left main is probably crucially important. So I know there's been a vogue with the radial approach to do the right, because people go up with the Judkins right because they struggle with getting up the radial artery. I'm not sure that's entirely correct. So some of us from the old school still believe that we should look at the left main first and define it, particularly in an elective case. Because you could be doing lots of shots willy-nilly of the right coronary artery and not know the state of the left system. Okay. So what do you think about your guide wire position there?
Bit bent, it's at the root.
Yeah, I think if you let it, I mean, what's the issue of having the wire doing that in the root?
Oh, it could go into the wrong place. There's too much length in there.
And you don't want that tip causing damage anywhere. So ideal is just above the aortic valve, isn't it? And keep tension on the wire. That's right. So this is Judkins left 4. Yep.
Okay, so I've got the wire going up. We've got the catheter preloaded, following the wire as we're going in. Okay. Let's get my wire out.
So now that you're up in the aorta, you've connected to pressure, what's the first thing you look at?
So the pressure tracing, the first thing, making sure I'm not...
How does that look to you?
It looks okay. It is a bit damped, but it's a good waveform, good pressure I can see, and it's consistent with the previous non-invasive pressure. So just make sure that I'm in the left coronary ostium. Okay. Then if you've still got a good pressure trace, no ECG changes or anything, I would test and see where I am. Ensure that I get a fluid to fluid first. I'd sack back on the catheter or draw back. Now I give a small test. Okay. I can see I'm in the left coronary artery ostium.
What do you think of the sizing of the catheter then?
So the catheter seems to be a bit, well, it's undersized for the size of the left main. So if I want to get a good injection, I'm going to have to get a good opacification of the coronary artery all the way down. I need to give.
What do you mean undersized for the left main? So that's a Judkins left 4.
So Judkins left 6 French. Yeah. Oh, the size of the aorta, you mean? It fits the aorta nicely. Sits at the back wall of the aorta nicely.
So how would you know if that was undersized, i.e. if you needed a JL5 or...
It wouldn't be supported at the back, and it would be flipping, and it wouldn't be sitting...
So it'd be much more horizontal, wouldn't it?
Yeah.
And if it's very vertical, then you need a smaller size. Yeah, excellent. Okay. So you think you've got a good position there from that test. So what are we going to do next?
I'm gonna go into the first year I'd like to take. So we can start with a PA caudal.
Why the PA caudal?
It will give us a good appreciation of the circumflex. It won't give us a very good idea of the left LAD though, or the left main. So if we want to appreciate that first, we could start with the LAO caudal or a spider view.
What's wrong with the AP view that you're in?
We could try the AP as well, yeah.
So what's the most critical lesion?
Left main stem.
So the left main stem is probably seen very well in that view that you're in anyway, along its entire length, both the ostium and the distal aspect of it and the body of it, yeah? So shall we set up for an AP view?
Of course.
So you want me to mag up?
Yes, please. Okay. So
and then are you happy with that position, or do you want me to move things?
So, well, LAO8, give us a very small test and see. Yeah, so I think we need to move and get bring the catheter towards the top of the screen.
So you want the catheter up to the top
Yes.
of the screen. So let's move the patient first, and then you want the catheter.
And that's
that
it, towards
way, okay.
the top left. I'll give another small test. Yeah, so that's a much better
Okay.
view. And I'm going to check my pressure tracing, which is good. Stable pressure, no ECG changes. So I'm ready to take a picture. With filters are in. And no, once we get the filters in, I think I'm happy.
Go ahead then.
Okay.
So, what have you seen so far then?
So I can't see a left main stem lesion. Okay. The left circumflex and distal LAD patent. I haven't got a good appreciation though of the proximal LAD, or the diagonal branches, or the OM branches for that matter. Well, I have seen the left main stem. Good.
So, where do you want to go next?
So if I think I haven't seen a left main stem lesion, and I think the most critical lesion, we can go on. We used to appreciate sequentially all the other coronaries. So I can't go to PA caudal now.
Yeah. Do you want to go to PA caudal? So let me just sort that centering out. PA caudal. So there you go. There's a PA caudal for you.
And the catheter seems to be, as in the catheter is in the towards the top and towards the left of the screen. Allow us to have a look at the arteries. Check my pressure again, which is good. No ECG changes. So I can take a picture.
So what can you see there then?
Okay, so she has. Oh, I'd like to play it again if I could, but to me, I can see the LADs missing.
Yep.
From that picture. It appears it's essentially a flush occlusion of the LAD.
Yep.
Of the proximal LAD.
Okay. And
with the diagonal vessel that's coming off and going towards that direction, not towards the lateral wall, but
in the PA caudal view, the left main proximal circ and the circ and the branches are seen very well, aren't they? And the proximal LAD.
Yes.
So you think there's an occlusion of the proximal LAD? Good.
And take more views and appreciate that better.
Okay. So which view would you like next if you think the LAD is occluded?
We should go to a cranial view next for the LAD. Okay. So should we go LAO cranial?
LAO cranial?
Yes.
Okay. What about AP cranial? Do you want to try that?
Yeah, we could try for a cranial.
Which one would you like?
Proximal LAD.
Should we try the LAO cranial? Okay, when you're ready.
So yeah, I've got good pressure waveform, no ECG changes, and my screening the catheter is in a good position. Okay. Yeah, so that confirms what I saw earlier. There's a flush occlusion of the proximal LAD, the diagonal coming off before that. Still can't see anything in the circ, and the left main is essentially not severely diseased.
What view would you like next?
So if I've confirmed that on this, I would like to go to the spider, LAO caudal, to assess the ostium of the LAD better, assess the location of the lesion and the left main as well, the distal left main.
So left main you're happy with, aren't you? Because you've seen that in... Is it happy with that one? Do you want to give a test there then? Okay, do you want me to cone down or collimate in any way?
Yeah, we should bring the cones in.
Okay.
Because that's... I think that's... Yeah.
That there?
Yeah, that's fine. Okay. Again, pressure tracing is good. No ECG changes.
So where's the occlusion in the LAD then?
It's the proximal LAD, just after the ostium, after the diagonal comes off, that's going towards the lateral wall, but then it's occluded. It's a very, very proximal occlusion.
Okay, what other views? So you've done an AP, PA caudal, AP cranial, and an LAO caudal.
Yeah, I'd like to do an aerial cranial as well.
Okay. So let's see if I can get you that view. So we probably need to open out the collimators and get rid of some of these filters. Okay. Are you happy with that position?
Should we bring the catheter more to the left of my screen, and I'll give a small test to ensure we're not missing the top.
Okay, screen for me then.
Yeah, I'll just give a small test. Okay.
So what do you think of that position?
I mean, it's good, but we're not quite appreciating the proximal LADs. For shortening the proximal LADs, don't think it's going to be, might not be that useful.
Okay. Do you want to just, yeah.
So if I do it again, I can see, I mean, it's confirming the occlusion, but it's not giving me much more information.
No, but it confirms that the LAD is
Yes.
included there. Okay. So you've taken a picture there?
I haven't.
Okay.
And again, diagonal coming off, and the circ appears to be unobstructed.
So what would you like next?
I can do an aeriocaudal as well. Just have it. That will give us a closer look of the circumflex again, and its proximal segment and the OM branches.
Okay, there you go.
So good pressure, good position. Take a picture. Good. Okay, so it hasn't changed anything in my assessment. Still it's got an occluder LAD, patent circle, no significant left main disease.
So you're happy with that? What are you going to do next then?
So basically, well, I'm going to change over and have a look at the right side. Mm-hmm. So first of all, I need to disengage. If I'm in the radial axis, I'll also be, once I'm out, thinking about giving some heparin as well, if I haven't given any heparin. But
the radial, you'd give heparin a lot earlier, wouldn't you?
yes. Just before. So I'll go in PA or yeah.
Okay.
Yeah. Just disengage. Okay. Use my J-tip wire to exchange catheter over the wire.
So Kyriacos, so you've now reintroduced the wire and you're coming up with a Judkins right 4, is that right?
Yes.
Okay.
Waiting for my catheter to track on my wire. There we are.
So maybe a bit far with the catheter at that point, do you think? You were?
Yes, I went in too far. So I pulled it back, so I'm going to get my wire out at this stage. Okay. Connect. Again, aspirate, make sure we've got a liquid to liquid connection. Good pressure tracing. So I'll try and find out where the aortic root is. The root is just there.
So what view would you engage
So
with?
LAO,
Okay.
Straight LAO.
Okay, so you're screening there, maybe a bit too much radiation, but okay.
Now torque the catheter clockwise and then lift up.
So what's happening there?
not transmitting the torque very well into the, like the catheter's not the root. Yeah. I'm actually not quite sure what's happening here. Why is it not?
So you're getting sort of stuck down near the aortic valve.
Yeah.
Maybe the aorta is slightly more horizontal than you think. Maybe you want to bring the catheter back a bit more before you torque it. A bit higher up. Try from up there. Okay, there you go. Too far. Okay.
It's probably
So,
there.
what's your pressure doing?
Pressure is good, 120
Okay.
over 80, so I did a small test.
So there you go. So I think you were just getting caught up quite low down in the aorta, weren't you? Okay. So what would you like me to do?
So we'll take a picture, mag up and take a picture in the LAO view. It's best for appreciating the ostium and the proximal RCA.
So shall we set up? So if you screen and then we can... Let's mag up for you.
Okay, you
Okay,
should bring the catheter a bit higher. That's
Up there?
yes, it's a bit higher.
I don't know what's happening there. Oh, I know what it is. Okay.
So still got a good pressure trace, no ECG changes. I'll take a picture here.
So what can you see there?
So there's a stenosis in the proximal portion of the RCA just after the ostium. Doesn't look to be severe angiographically based on that, but I wonder if it's not very clear, it's a bit hazy. So I do wonder if there's any thrombus burden there.
So what view would you want next?
We can do a PA cranial. It will help us appreciate the more distal.
Is that what you normally go to? Or?
Can do 20/20 as well, which equally
Give
helps
me a little
us.
test there. I'll just move the table, sorry. Okay. So you want to go to 20/20 or PA cranial?
Let's do a 20/20. Okay, yeah, I'm happy with that position. Good pressure, good trace. Okay, so the 20/20 is better for showing me the distal PLV branches and opening up the distal RCA. I can't see any more problems there. It's not very good at giving me a good view of the proximal RCA, but I can still see the stenosis there.
What about filters in that last shot? Were you happy with those, or do you think there could have been?
We could have put the filters in the size and more, yeah.
Yeah. Okay. Should we just take a picture there and just see what that looks like with those filters in? Okay.
Yeah,
so you're still not sure about the significance of the lesion proximally. You're quite happy distally. What else? What would you do next then?
Could do an REO view to assess the mid portion as well of the RCA.
I mean, the thing is, you've only done left-sided views at the moment, so
Yeah.
you definitely need to get one in the right on the right. So, what kind of view would you like from the right?
An REO,
Okay, straight RAO.
straight REO.
Okay. Let's have a look then. See what you've got in your RAO. Tell me if you want to move things.
Yeah, so let's give a quick test just to orient. Okay, that's good because it allows me to
Do you want me to?
expand all that. So bring the filter in from the right side. Yeah, that's great. Thank you.
So, what do you think?
Again, distal and mid portion of the RCA are unobstructed. The proximal portion I still haven't been able to see any better from these views because it was best appreciated from the left side, from the LAO
the straight LAO picture from the left-sided view.
So you're still not sure about that very proximal bit. Is there any view that can help you here?
So I need to think of what will open up the ostial and proximal RCA. So it's going to be a left-sided view. Options will be, we've done it 20.
Laterals are usually good for what portion of the artery?
Lateral will be, it's good for the origin, isn't it?
The mid usually is very good, and the branch with the RV branch. But let's see what it does here, because it's an acute bend at that top end.
Okay. Good pressure. So it's still illustrating the same lesion. I mean,
Doesn't look flow limiting, does it?
no, it doesn't look flow limiting.
Shall we do a LAO caudal?
Spider.
Okay, let's center up for you.
Yes, thank you. Okay. And filters are in. Good pressure. Okay. And again, I've seen the lesion. I would call it angiographically mild, maybe even moderate or worse lesion. Doesn't seem to be flow limiting.
It's sort of an ectatic portion, isn't there?
It's an ectatic portion of the vessel. I've got a myocardial perfusion scan. Didn't show any ischemia in that territory either. So based on the symptoms, and we have found a positive finding that correlates with your stress test, I wouldn't necessarily intervene on that now or interrogate it.
Would you do any other, after the coronaries, would you do anything else?
We'd consider doing an LV gram to assess LV function. We obviously do a pullback as well as part of the examination, but especially because you've got a proximal LAD lesion, she might be considered for a surgical revasc, and that would be important in the surgical consideration as well.
Very good. Thank you very much.